This is Dr. Eddie Phillips bringing you physical activity counseling. In the first part, we'll look at office-based counseling. So straight away, let's understand that actually counseling our patients about physical activity is feasible, effective, and cost-effective. To make this point, let's look at a couple of studies about physical activity counseling, in this case, the activity counseling trial. This study had 54 primary care physicians who were trained to integrate just a short 3 to 4 minutes of physical activity advice into their routine visits, and that was, of course, with sedentary patients. They found that 99% of the patients received the initial physician advice, so it was quite well accepted as part of the study. 83% of the providers spent less than 5 to 6 minutes, and almost half spent only the 3 to 4 recommended minutes. And yet, they said, interestingly, it really didn't take that much longer. 63% said it did not increase the length of the visit. And 83% of the primary care doctors said that it was an asset to their clinics to include this. So it was sort of feasible and acceptable by the physicians. In regard to the efficacy of the counseling, in this study from the Archives of Internal Medicine from 2009, they looked at 56 family physicians, about half were intervention, half were control, and they collected over 4,300 physically inactive patients, again, split almost evenly. And then the intervention that the physicians provided was a physical activity prescription to a subgroup of those attending an additional appointment. They looked at the main outcomes after 6 months, and they did a 7-day physical activity recall. So interestingly, the average increase in physical activity was 18 minutes per week, which actually is a good start towards the 150 minutes of recommended physical activity. If you looked at it from a perspective of how many patients would you need to speak to, or the number needed to treat in order to get an individual up to the physical activity guidelines, that number was 26. So speaking to 26 patients in this study, you could expect that at least one of them would now reach the physical activity guidelines for Americans, again, 150 minutes per week. In this case, this meta-analysis included 13 papers of primary care physicians counseling, and the major outcome was self-reported physical activity by the patient. It was found to be a small to medium positive intervention at 12 months. Odds ratio there is 1.42, but the number needed to treat to get a sedentary adult to meet the internationally recommended levels, again, the 150 minutes per week, was only 1 in 12. So the finding was that the promotion of physical activity to sedentary adults recruited, again, in primary care, significantly increases physical activity levels at 12 months. And that, again, was measured by self-report. So the next question about physical activity counseling in primary care is whether it's cost effective. This was a systematic review, and interestingly, they reported the cost to the practice of moving one person, one patient or study participant, to the active category at 12 months. And the cost ranged from $500 on one end up to $5,000. As we looked at in earlier talks, the money saved by getting your patients more active was over $1,200 per year of medical costs. So the return on investment here could be sought in as little as several months, 3 to 4 months, if you manage to move someone effectively or efficiently at $500. And even if it costs $5,000 of intervention to move someone, the return on investment still comes within a few years. So they found here that most interventions to increase physical activity were cost effective. And the brief exercise advice could be delivered in person, for instance, commonly in the office. It could also be done by phone or mail. And also, it seemed to be more cost effective than sending patients to supervised gym-based exercise classes. So, with all of these findings, the U.S. Preventive Services Task Force encourages healthcare providers to counsel on lifestyle modifications for patients with known risk factors. And at least in my practice, that's most of my patients. So now let's look at the techniques for office-based counseling that you might employ in your practice. These will include setting goals with patients, helping them find the social support that they need, monitoring themselves and their activity levels, and importantly, what can we do to support them when they have a relapse down the road? So, as is written in the new 2018 Physical Activity Guidelines for Americans in the draft report, they point out that under behavioral techniques, that there is now strong evidence that demonstrates individual level interventions can increase the volume of physical activity performed both by youth and by adults, especially when the interventions are based on behavior change theories and techniques. And that's why we'll discuss those that are based on behavior change theories and that are evidence-based. For purposes of this talk, we'll consider the 5 A's. This is just a framework, but it will help structure the intervention. The first will be, when you're talking to your patients, assess them. What do they know about exercise? What are their behaviors currently? What do they believe about exercise and physical activity? We'll then move on to advising them. In this case, it's specific information about the health benefits of the change. And I'll make the point now and again that tailoring that to what the patient is presenting with and what their goals are is much more likely to be successful than just providing an array of all of the benefits of exercise. We then move on to agreeing with the patient. This is collaboratively setting goals based on the patient's interest. How confident are they in their ability to change? You need to meet them where they are. We then move on to assisting, in this case, overcoming barriers. What will it take to get them out walking? Or if they wish to go dancing, what kind of barriers are there? What sort of strategies or problem-solving techniques? And what sort of support is out there? So again, this is now moving them into action. And lastly is arranging. If there's a specific plan, how are we going to follow up? Are we going to have them come back for another visit, send a mail, send something by mail, call them by phone? How are we going to arrange for them to fill the exercise prescription? So let's go through the 5 A's one by one. As you look at the slide, we're simply asking the patient, as we have already done in the physical activity vital sign, do you exercise? If yes, the next question is, what kind of activity? And I could tell you from personal experience that just asking the question will generate all sorts of responses you'd never imagine. For instance, an 85-year-old woman who still likes to skip rope because it reminds her of her youth, or older adults that you might not picture swimming or in competitive sports. So you need to ask what type of activity, how hard, what's the intensity level, for how long and how often. So you're basically asking them to describe, as we've talked about, the physical activity or exercise prescription, how are they filling it? If they don't exercise, the discussion is different. We would talk about why you're not exercising or what might it take to exercise, and we'll go down that path in a little bit. So the 5 stages of physical activity represented on this circle parallel the stages of change, or the trans-theoretical model, which we'll go over in the next few slides. As you enter into the circle, many, or actually most of the patients may be found on the couch. From there, this patient may turn, hopefully, to someone who's at least thinking about exercise. So they're moving from a pre-contemplative to a contemplative stance, like maybe I will do this, let's talk about it some more. We then move into preparation. This will be someone who said, yeah, I might be able to get out of the house and go for a walk and join someone, but as you notice on this slide, they may also temporarily exit. Or with a little bit of counseling, you can move them up into the action phase, or they become sort of an activator. From there, we hope that they move into more of a maintenance or become a regular exerciser. At that point, if they incorporate exercise or physical activity into their lives, they might be able to sort of exit this circle. However, for a number of people, they'll fall into relapse, where as much as they've tried for several months, well, they've lost the habit again, and we go through the cycle again. And it need not necessarily be in this order, and it need not necessarily be as neat as I've mentioned, but we're always going through the cycle for different behaviors. In this case, we're focusing on physical activity. The same sort of algorithm is broken up in this case by the stages of change. And you could start at the top of this and work your way through the algorithm. The simple question is, are you accumulating at least 30 minutes of moderate intensity physical activity on most 5 or more days of the week? That's sort of a basic question that would get you the 150 minutes. However, I would give full credit to someone who's doing 75 minutes twice a week. So you're really asking the first off, are they getting their 150 minutes? As you work your way down the algorithm, there are 5 outcomes. And again, you'll find in the bottom left, someone who's pre-contemplative, they're not ready, they're not interested, contemplative, or they can be in the preparation, the action, or the maintenance stage. So this is just another presentation, and this has been used in several studies as a way to put the patients into the proper bucket so you know how to best help them. And just as a clinical point, if someone really is pre-contemplative, moving on and trying to push them into exercise is probably not going to be effective on your end, but just giving them some more information will be acceptable to the patient and won't take up too much time. This is the same sort of thing from a stages of change angle for the couch potato all the way through the active exerciser, and you can see what they're thinking. And again, it's all about what the patient is thinking. That's the most important perspective. We move on to advise. On the exercise prescription or referral form in front of you, we again cite the physical activity guidelines, which you know quite well. And again, this is where it's most important to provide a tailored knowledge and advice. So we want to match up, and this is what I do with my patients. Why did they come in? What is it they're looking for? If they really want better glucose control, if they're looking to maintain their weight or to manage their weight or improve their fitness, then I'll tailor the message to what they're looking for. It's the same exercise. It's just sort of what is most acceptable and what are they looking? What are the options for physical activity? Is it the part where they're trying to decrease sedentary time, which is also important? Are they looking to get into short bouts of exercise? What components of fitness are most important to them? So the self-stated goals are the most important. Knowing where they are in the stages of change will help you tailor your message so that you're providing the right information at the right time, the right encouragement. And interestingly, under one of the last points, self-efficacy is the opportunity for the individual that you're treating to become more confident. A small goal achieved will improve their self-efficacy. This is another kind of clever way of my activity pyramid, which I guess is a takeoff on the food pyramid. And it's interesting if you start at the bottom, the everyday activities of getting to work, perhaps by biking, maintaining your yard, the walking that we do. Next up in the blue level, the aerobic activity, that's where you get your 150 minutes. At the orange level, the strength and flexibility that we've talked about a couple of times a week. And the smallest little part is the prolonged sitting at the very top. Moving through the 5 stages or the 5 A's, we talk about agree. What has the patient now committed to, and what can you do to formalize it in the exercise prescription? In this case, we talk about the aerobic versus strength and whatever is going to work for them, the number of days, the minutes per day, and the total minutes per week. They need not start at the 150 minutes if they're not ready for that yet. In terms of goal setting, you've heard of SMART goals. We'll take it a step further. The SMART C goals include the usual specific, measurable, action-oriented, realistic, and time frame of a SMART goal. And now we've also added that it should also be self-directed and it should also be evidence-based. In setting goals, it's important for them to be specific. So on the right, the simple idea, oh, I'll start walking after dinner, is not specific enough. Something more along the lines of, I will walk 2 miles after dinner twice per week, in this case, Tuesdays and Thursdays, is more specific. We also encourage patients not to set too many goals. They should also be flexible in their goals. Goals change. Once they're achieved, patients often want to move on to a more challenging goal. You also need to follow up. And also many patients, once they sort of catch the bug or they realize how important exercise is, may straight away say, I'm ready to run a marathon. And they may be ready to run a marathon, but I would still give them a smaller goal to start with that will eventually get them towards a larger goal. So being realistic in their expectations as a start is important. In the assisting part of the 5 A's, we're now going to move on and figure out who might help them fill the exercise prescription. What sort of social support do they need? Are they going to do some sort of monitoring of themselves, perhaps with a device? Again, this is where relapse prevention falls in. In the slide under usual choice versus healthy alternative, you can see the transformation and the opportunities that I like to call lifestyle exercise, which is engineering physical activity into your day. This might be the best place for someone to just start to pick up those extra minutes by taking the stairs, by parking further away, and not spending their time circling the parking lot looking for a spot. Even a 10-minute walk at lunch is going to help. So these are opportunities to help them start reaching their goals. We've talked about the need for social support. We're social beings, and having people who are either going to work out with us, neighbors who might even join the walk, partners or family, is actually a really important part. And I love this little graphic here from Steve Blair's work that's labeled My Support Troops. Who is going to be there with you? When can you call upon them? How are they going to reward you for doing this? It's a team that will make most patients more successful. One of the important pieces of this stage is the self-monitoring. These days, we live in a world where everything that we do can be quantified. We've listed the smartwatches and GPS and heart rate monitors. We're moving into web-enabled fabrics that will be able to measure our activity. But it's got to be appropriate to the patient. Maybe a step counter is all that they need. Maybe it's simply an app on their phone. But the purpose here is to monitor the progress and to give some feedback to the patient. So problem solving is an important area because despite our best plans and the way that we're trying to help our patients, problems will come up. So helping someone identify them, develop a strategy and a way to act and assess and overcome a problem is important. So someone who, even if they commit to walking 5 days per week, if the weather turns bad, if it gets cold, what's their plan? What happens if they're not feeling well? What are the alternatives? These are all aspects of problem solving. Relapse. Even the best intentions will often get derailed by anything from people visiting, travel. It could be something happy like a wedding or a funeral or anything, or the period of illness. It's really important to plan for relapse and right away to stress with patients that you almost expect that something's going to happen. I've gone so far as having patients actually write a note to themselves about why they're starting to exercise, what their commitment is, and they put it into an envelope and they stow it in a book in their house where they know they'll be able to find it. And down the road, whether it's a week, a month, or 3 years, if they fall off the wagon and they realize that they have lost the reason for exercise, they'll actually open up this envelope, sort of a break glass in case of emergency, read what inspired them in the first place. So along there is a little bit of cognitive restructuring and also getting people away from like an all or nothing. So many patients come in and they figure when we talk about physical activity, it's a marathon or nothing. And I'm thinking an extra 100 or 1,000 steps are going to help get them back on track more than an all or nothing attitude. So the follow-up or arranging for follow-up, you can decide how to do that. Often a telephone is enough. We'll talk about other people that can take on the job at this point, whether it's a wellness coach or they're in a group, or there's other fitness professionals that may do a lot of the follow-up. However, when the patient comes back to you, I would encourage you to, again, ask them about their physical activity. So the arrange part of this is exactly who do you refer them to? Who's going to help them fill the exercise prescription? Is there a health and fitness professional in your practice, in your hospital, in the community that is able to take on the patient with this prescription and then guide them forward? So we've gone through the 5 A's. We've tailored the recommendations as best we can. The goals are hopefully behavioral. We've given them practical resources and always demonstrating empathy. And we're also willing to share our experiences as much as you're comfortable. And then you're providing some sort of follow-up. So on to physical activity counseling. Now we're actually going to consider how to fill the exercise prescription. We'll explore the resources that can help ensure sustainable change. Sustainable is the key word here. What's going to stick with the patient? And this might include a clinic, a health promotion clinic, or a virtual team. And this may include, as we'll talk about, health coaches that may be out there, wellness coaches, exercise physiologists, and other health professionals that can help your patients adopt and sustain a more active lifestyle. So let's be familiar with what is available as a consumer and as available, and let's work together as a team. And very often, you're going to be using external resources as well. However, let's consider your clinic, your practice setting, to be a healthy clinic. And let's look at a report from the American Journal of Preventive Medicine in which 66 primary care physicians that were spread over 23 practices were compared to the community control. Their instruction in brief physical activity counseling was offered by this group of PCPs, along with physical activity promotion resources. In this case, when the study was done way back in 2004, that included print materials and pedometers. So there was a 31% increase in the likelihood of recalling the advice from the primary care physician if they were given the advice as well as some sort of resources, print materials and pedometers, compared to those in the community that were given none of this, who had a 16% decrease in their likelihood of recalling the advice and getting more active. There are many available healthcare providers that can help to promote and sustain exercise, and working together as a team is going to be our best bet. So who might this include? Physical therapists are high on the list, exercise physiologists, coaches, and personal trainers. Let's start with physical therapists. They most commonly see patients after they have an injury, before or after surgery. They are best at providing therapeutic exercise or applying modalities to relieve pain and improve function. They also can help with the use of equipment that will be introduced to patients. The pros of referring to a physical therapist is that they are highly trained. These days, the standard is that they are doctors of physical therapy. According to their experience, you may find someone who's got significant experience. They carry insurance, they are credentialed, licensed, and there's an established mechanism of communication. We know how to communicate with them through the medical record if they're in your system, or through other means such as letters or through electronic means. They do require a medical diagnosis, which is usually easy to come up with in terms of what the patient is presenting with. Copays, we've listed $20 to $40. They can actually go much higher. And the insurance may limit the number of visits. Their time and their training is focused in therapeutic exercise, but my happiest moments with physical therapists are those that are willing to work on changing a therapeutic exercise, for instance, strengthening your muscles around your knee in order to overcome pain, to then making the gentle switch towards a therapeutic exercise, towards a lifetime of exercise. So physical therapists can be very helpful in terms of pushing along a patient towards more physical activity. Coaches, this is a hot area, rapidly expanding, and let's consider a few different definitions. The fitness coach is a credentialed exercise professional. They're going to use coaching skills to help with personal training and improve with fitness outcomes. Wellness coaches are, again, credentialed, and they could help with wellness, such as physical activity. A health coach is a little bit better able and may have more of a medical background or a nursing background to help manage medical conditions such as heart disease, diabetes, arthritis, cancer, and others. So the pros of a coach is that they are usually quite accessible, most often by phone. They can target behavior. They work on a sort of a strengths-based approach. What is the patient, or in this case, their client, good at? The certification of health and wellness coaches has newly been established as an international certification. And very often now, employers or even insurance companies will provide access to the coaches. The cons are that it's still private pay unless your employer or insurance company is providing it. Their experience can be variable. And the path of communication, because they usually don't have access to medical records, or they're usually not HIPAA compliant, although they can be if they're working within the healthcare system. Clinical exercise physiologists are health professionals, and they are quite good at being able to prescribe and supervise exercise prescriptions. They are highly trained, they have significant experience, and they can be insured and credentialed. However, they have limited availability, and while many exercise physiologists work on clinical studies, it's much harder to find them available in the community, although if you look, you can find some excellent registered clinical exercise physiologists. There's much lower chance of being covered by insurance. However, there is some availability, or they might take private pay. Personal trainers are quite accessible. There is a wide variety, whether you're looking for someone to help with a specific activity. They're usually private pay. The knowledge and experience, of course, can be variable. They also lack a established method of communication, and there's no clear certification for this entire industry. However, if you are referring to a personal trainer, I would encourage you to look for someone who holds a credential, which is certified by the National Commission for Certifying Agencies, the NCCA. And there's a few listed here, and we'll go into them on the next slide. So at best, you can find the better personal trainers by word of mouth. Your patients may report back. You can interview them if you wish. You might also check what their insurance is or where they're working. And this is a list of agencies that are certified by the NCCA. So I would look for someone who holds one of these certifications. So there are additional resources to help your patients. They need not necessarily see an individual. They may need a program or a device or simply a park to go to. They can also use technologies these days, and this is actually from the recent 2018 report, that the technologies, including the wearable monitors, smartphones, computer-tailored print interventions, the internet, is really where much of physical activity promotion is going. So other external resources beyond referring directly to an individual might be a wellness program. You may inquire what they have at work and what's available in the park system or the local gyms, and what they're comfortable with in terms of web programs and apps. And old-fashioned resources can still work. Pen and paper, the exercise prescription that we've talked about, can still be a motivating device. Handing out material, even on paper, directly from your office, some tracking logs, even a few sticky notes, can actually be very motivating to patients. They put them on their refrigerator, which they visit frequently, and they can see that they have been or they've committed to an exercise prescription that might get them going. So don't give up on the old-fashioned as well. In terms of wellness programs, I'd encourage you to look at the National Physical Activity Plan, which has the goal of one day all Americans being physically active, where they will live, work, and play in environments that facilitate regular physical activity. There's a wealth of material associated with the National Physical Activity Plan. Worksite wellness is quite popular and available, especially in larger self-insured sites. In this one older study from Motorola, they showed that for every dollar that the company invested in wellness benefits, they saved nearly $4 in lower increases in healthcare costs and lower medical expenses for lifestyle-related diagnoses that we've talked about, such as obesity, high blood pressure, and stress-related illness. Again, a little bit more evidence that medical costs fall for every dollar spent on wellness, which often include physical activity, and even absentee costs fall. Patients show up more at work and are better able to participate. Simple devices provided by your office or people can order off the web can be very motivating. And I'm a big fan of a resistance band. Here they show the ones with handles that you can carry when you're traveling or have at your office just for a break. So even providing a simple device can be a great message to your patients. Web programs are endless. We've listed a few here. They can provide everything from goals associated with participating in a team to incentives and badges and all sorts of feedback. And they can also share it with you or with their wellness coach or their personal trainer. Gyms abound. Patients will look and sometimes be very motivated, but they'll also consider the cost and the location, what's available. And for the right patient, it's a great option. but for many patients, this is the last place they want to exercise. So I encourage you to check out the available gyms so you might be able to advise them on everything from the high end to the $10 a month gyms, which may be open 24 hours a day, which takes away one more excuse that they can't find time during their day to go. Parks and the idea of outdoor recreation, or even this being part of a nature cure, abound. And again, knowing in your community what's available for walking trails, there are heart trails, hiking, all of these things. The more familiar you are, or if you have some resources or even a map in your office, it may encourage your patients to go. There are even programs where a prescription is written for going to the park. So summary and takeaways. Office-based counseling we've described and we've given evidence is feasible, effective, and cost-effective. We've talked about the techniques for working with your patients, helping them set goals, finding the social support, monitoring what they're doing, and a specific call out to helping them with the expected relapse. And the resources that are available, whether it's a person or a program or a place or an app, can include and help improve sustainable change. You can pull together a team. It can be a virtual team as well. There are other health professionals out there, and we've detailed a little bit more about physical therapists, coaches, clinical exercise physiologists, and personal trainers. And we've also touched upon other places that people can go, whether it's a park or a gym, or whether they're using their phone to help get and maintain increased physical activity. Technologies abound, and I encourage you to become familiar with them and to participate and be able to maybe even reflect on whether they help you or whether they're of little or no interest. And this is a specific call out from the 2018 Physical Activity Guidelines report. Behavioral techniques have a strong evidence-based, and it shows that the individual level interventions, that's the act of us talking to our patients, can increase the volume of physical activity at all ages.